3 patients, gone, this year alone. I want you to sit with that for a second. 3 people who came to see me regularly, people whose families I knew, whose grandchildren I'd vaccinated, people I'd shared small town dinners with, are no longer here. And in every single case, there was a warning sign hiding in plain sight that nobody caught. Not the specialist they eventually saw, not the urgent care clinics, not even me for longer than I want to admit. The warning sign was in their feet, and I am going to carry that with me for the rest of my career. Now I know what you're thinking. Doc, what do feet have to do with anything? That's exactly what I thought when I was a second-year resident and my attending grabbed a patient's chart, looked up, and said something I never forgot. Sam, if you want to know what's happening in the bloodstream, start at the floor. I didn't fully understand what he meant for another decade, but after 28 years in practice, mostly right here in a small town where I know every patient by name, I understand it completely, and I wish I'd understood it sooner. Diabetes is the great pretender. It moves through the body silently for years, sometimes a decade or more, before it announces itself with something catastrophic. And while it's doing that silent damage, while it's burning nerve endings and clogging blood vessels and quietly eroding organ function from the inside out, it is leaving clues. Specific, visible, undeniable clues. Right there at the end of your legs. The problem is most people, and if I'm being brutally honest, a lot of doctors, don't know what to look for. Or worse, they see the clues and assume they're just part of getting older. I'm going to change that today. I'm going to walk you through exactly what I check on every patient over 50 who comes through my door. 7 signs in your feet that could mean you have diabetes right now and don't know it. But before we get to any of that, I need to tell you about Harold. Harold was 67 years old when he came in about a blister. Just a blister. He was a farmer, had been his whole life. So he was built for tough conditions, sore muscles, calloused hands, the general wear of physical work. He barely thought the blister on his right heel was worth mentioning. He almost didn't bring it up at all. He told me right there in the exam room, I only came about this because my wife wouldn't stop nagging me about it. He even laughed when he said it. That blister had been there for 3 weeks. In a healthy person with normal circulation and intact nerve function, 3 weeks for a blister is already beyond what's acceptable. But what concerned me immediately wasn't just the blister, it was everything surrounding it. The skin on Harold's foot was dry as parchment, almost papery to the touch. The color on the bottom of his heel was a dull, dusty red, instead of the healthy pink I'd expect in a man his age who was physically active. And when I asked him how much it hurt, he looked at me and said, honestly, Doc, not that much. A little tender when I first put my boot on in the morning, but mostly, I forget it's there. That phrase, I forget it's there, is one of the most alarming things a patient can say to me about a wound on their foot. Pain is your body's alarm system. When that alarm goes quiet, specifically in your feet, it means the nerves are damaged. And damaged nerves in the feet of a 67-year-old man have one primary explanation: prolonged, uncontrolled blood sugar. Harold had never been formally diagnosed with diabetes. His previous physician, who retired 3 years prior, had noted that his fasting glucose was borderline, 118 milligrams per deciliter, at his last physical. But no HbA1c had been ordered. No foot exam had been documented. And Harold had never been told what borderline actually meant in practical terms, what it meant for his future, what it was quietly doing to his body while he kept on farming and living his life. What it meant was this: Harold's blood sugar had likely been elevated for 5 to 7 years at minimum, long enough to cause what we call peripheral diabetic neuropathy, nerve damage that begins at the outermost points of the body, the fingertips and the feet, because those are the farthest from the central blood supply and the first to suffer when that supply is compromised. Long enough for the small blood vessels feeding those nerves to begin narrowing and stiffening, cutting off the nutrient delivery that healthy tissue depends on. A blister that should have resolved in 4 or 5 days had become a 3-week-old open invitation for bacteria. And Harold had felt almost nothing, This is the insidious, cruel architecture of type 2 diabetes. And this is what I need you to truly understand before we go any further. It does not announce itself the way you imagine a serious disease should. There is no single dramatic moment, no collapse, no obvious alarm bell. Instead, quietly, over years, the elevated glucose does two devastating things simultaneously. It destroys the nerves that would warn you something is wrong, and it destroys the blood vessels that would heal you when something goes wrong. It dismantles your warning system and your repair system at the same time. By the time most people find out, the damage already has years of head start. The CDC puts it in numbers that should stop all of us cold. Approximately 37 million Americans currently have diabetes, and roughly 1 in 4 of them, about 8 to 9 million people, have no idea. They haven't been diagnosed. They haven't been screened. They are going about their daily lives right now with a disease that is quietly working through their nervous system and vascular tree, leaving behind exactly the clues I'm about to show you. Some of those people are watching this video, and if they recognize the signs I'm going to describe, they need to act on that recognition immediately. Not next month, now. What ultimately happened to Harold, I'll come back to that. I promise. But first, I want to tell you a little about why I believe I'm qualified to have this conversation with you, because I think context matters. I want to be upfront. I have not published landmark trials in major medical journals. That is not my world. For 28 years, my world has been a community practice where most patients are farmers, retirees, and working families who drive in from surrounding counties because I'm the closest physician available. People who come to see me when something finally hurts badly enough that they can't rationalize ignoring it anymore. That reality has given me a front row seat to what happens when chronic disease goes unmanaged, and an equally clear view of what happens when it's caught early and handled properly. I trained in internal medicine and family practice, and metabolic disease management has been central to my work for the entirety of my career. I've pursued continuing education specifically in diabetic neuropathy, peripheral vascular disease, and wound care management. I've collaborated extensively with podiatrists and vascular surgeons, and what I've learned through those consultations has shaped how I examine patients in ways that no textbook fully captured. The guidance I'll share today aligns with recommendations from the American Diabetes Association, CDC screening protocols, and clinical standards I've reviewed from institutions including the Cleveland Clinic and NIH. The standard of care says diabetic foot exams should happen annually for every known diabetic patient. The standard of care says screening for type 2 diabetes should begin at 35 for most adults, earlier if risk factors are present. The frustrating gap, the gap that cost me 3 patients this year, is the space between what the guidelines say and what actually happens in the exam room when time is short, when patients downplay symptoms, and when a borderline glucose number gets noted in a chart and never followed up. I'm trying to reach across that gap right now, directly to you. So let's get into it. 7 signs in your feet that can indicate undiagnosed or poorly controlled diabetes. And I want to state clearly, this is not self-diagnosis. This is self-observation. You are building a case, a list of observations that you bring to your doctor and use to ask the right questions. Think of yourself as a medical detective gathering evidence, not a physician rendering a verdict. Sign 1. Numbness, tingling, or a burning sensation, especially at night. This is the hallmark presentation of peripheral neuropathy, and it almost always starts in the feet before it migrates upward. The distribution matters. It tends to begin at the tips of the toes and move proximally toward the ankle and lower leg in what neurologists call a stocking pattern because it maps onto the area covered by a stocking. Patients describe it in very different ways. Some say it feels like their feet are asleep all the time, even when they're moving around. Others describe a deep burning or aching that's worse in the late evening or at night. Still others simply notice that when they step on something uncomfortable, a pebble, a toy on the floor, the sensation is muted or delayed. Any of these presentations, particularly if they're progressive, warrants a conversation with your physician about formal neuropathy screening. Sign 2. Any wound, cut, crack, or blister that isn't healing on schedule. We touched on this with Hurl, but the mechanism deserves a clear explanation. In a person with healthy circulation and intact peripheral nerves, a minor wound on the foot, a cut, a cracked heel, a small blister should show visible improvement within 7 to 10 days and resolve completely within 2 to 3 weeks. When elevated blood sugar has damaged the blood vessels and nerves simultaneously, healing becomes profoundly impaired. The blood vessels can't deliver the immune cells and growth factors needed for tissue repair. The nerves can't signal that the wound needs protection. The result is what wound care specialists describe as a chronic, non-healing ulcer, a wound that sits open and vulnerable, sometimes for months, accumulating bacterial load and deepening despite treatment. If you have any wound on your foot that has been present for more than 2 weeks without significant improvement, that is a clinical red flag that needs same-week evaluation. Sign 3. Asymmetric skin color or temperature between the 2 feet. Healthy feet are remarkably similar. Similar color, similar temperature, similar appearance. Peripheral arterial disease, which develops alongside diabetic neuropathy as a consequence of vascular damage, disrupts blood flow unevenly. One foot or one section of a foot can become noticeably paler, more bluish, or mottled compared to the other. Temperature is equally telling. If one foot consistently feels cooler than the other to the touch, blood flow is being compromised. I make a habit of placing both hands on both feet simultaneously during every exam to compare. It takes 10 seconds and has changed the course of several patients' care. Sign 4. Hair loss on the lower legs and feet. Every time I bring this up with patients, I get the same look. Slight disbelief, then genuine surprise. But it makes complete physiological sense. The small hair follicles in the lower extremities are highly sensitive to reductions in blood flow. When peripheral arterial disease begins to limit circulation, the follicles lose enough nutrient supply that they simply stop functioning. Hair growth stops. Over time, the lower legs and the tops of the feet become noticeably bare. If you look at your lower legs and notice the hair is sparse or entirely absent in a pattern that's different from what it was 5 or 10 years ago, file that away. On its own, it's mild. Combined with other signs on this list, it becomes part of a meaningful clinical picture. Sign 5. Thickened, yellowed, brittle, or slow-growing toenails. Sometimes a fungal nail is just a fungal nail. I understand that. But diabetic patients are significantly more susceptible to onychomycosis, fungal nail infections, for 2 reasons that reinforce each other. Elevated blood glucose creates a systemic environment where fungi thrive. Simultaneously, reduced immune activity in the peripheral tissues means the body is less effective at fighting off those fungi. So while a single thick toenail in isolation might be nothing, a pattern of nail changes appearing alongside any numbness, any skin changes, or any healing problems should prompt blood work. Sign 6. Calluses forming in unusual or unexpected locations. This one is subtle, but extremely instructive for those of us who know what we're looking at. Everyone accumulates calluses in areas of friction and repetitive pressure. That's normal. Diabetic peripheral neuropathy changes this pattern in a specific way. Because sensation is diminished, patients unconsciously shift their weight distribution. Their gait adapts to avoid areas of discomfort they can't fully perceive. Over time, this puts abnormal pressure on parts of the foot that weren't designed to bear that load. Dense calluses form over the metatarsal heads, across the midfoot, in places where healthy pressure mechanics wouldn't produce them. A podiatrist can read these patterns the way a forensic specialist reads evidence. They tell a story about where the pressure has been going wrong and for how long. Sign 7, and this is the one I want you to remember most clearly, is the loss of response to light touch at specific points on the sole of the foot. In my clinic, I assess this with a 10-gram monofilament, a thin nylon filament on a small wand that delivers a standardized amount of pressure when bent against the skin. A patient with intact sensation feels it immediately at every test point. A patient with significant neuropathy feels nothing at some points or feels it inconsistently. You can approximate this at home without any equipment. Sit in a chair, close your eyes, and have a family member or friend gently press a folded tissue or the eraser end of a pencil against the ball of your foot, the heel, and the base of each toe. If there are spots where you feel nothing, or considerably less than you'd expect, that asymmetry is clinically meaningful information. I want to stop here for a moment because I know something about the people watching this. A significant number of you just recognize one or two or maybe three of those signs in yourselves. And your first instinct was probably to tell yourself, that's just my age. Everything hurts more. Everything heals slower. It's just getting older. I hear that rationalization every single week, and sometimes it's valid. But I need you to understand that peripheral neuropathy, vascular insufficiency, and impaired wound healing are not inevitable consequences of aging that you simply accept. They are frequently the fingerprints of a treatable metabolic disease. The distinction matters enormously because one path leads to management and reversal, and the other leads to a blister becoming an ulcer, becoming an amputation. For patients who want to be proactive between appointments, tracking symptoms, logging changes in sensation, noting when wounds appear and how they're progressing, there's a health tracking app some of my patients have been using that does exactly that. It helps you build the kind of consistent daily record that makes your doctor's visit far more productive. If that sounds like something that would help you, I've put a link in the pinned comment below this video. Worth checking out. Now, before I bring you the proof that these interventions actually work, let me address the two risk factors most people don't realize are red flags for undiagnosed diabetes. The first is simply being between 45 and 75 years of age. Risk rises steadily across that window and peaks right in the middle of most of my patients' lives. The second, and the one that surprises people most, is borderline or controlled hypertension. High blood pressure and type 2 diabetes are metabolic siblings. They share the same root mechanisms: insulin resistance driving vascular inflammation, endothelial dysfunction, progressive arterial stiffness. They travel together. If you have high blood pressure, even well-managed high blood pressure, and you've never had an HbA1c drawn, you are overdue for screening. Now I want to show you the data because the numbers are sobering in a way that I think will make everything we've talked about hit harder. A paper published in Diabetes Care established that type 2 diabetes is typically present for 7 to 12 years before formal clinical diagnosis. 7 to 12 years. Let that settle. That is up to a decade of elevated blood glucose silently damaging nerves, stiffening vessels, exhausting the pancreas, and beginning to compromise the kidneys and eyes, all before a single physician writes diabetes in the chart. The American Diabetes Association's data shows that more than 50% of people with diabetes will develop peripheral neuropathy during the course of their disease. And that neuropathy is the leading contributor to diabetic foot complications, which are responsible for more non-traumatic lower limb amputations in the United States than any other cause. Not accidents, not cancer, diabetes and its foot complications. The majority of those amputations began with a wound the patient couldn't fully feel, in a foot whose circulation couldn't fully heal it. A blister, a cracked heel, a small cut from walking barefoot. Tiny, dismissible beginnings with devastating ends. The domino effect is nearly mechanical in its predictability, which is precisely why it's so preventable if caught at the right stage. Now let me tell you about Margaret, because Harold's story is the reason I started doing routine foot exams on every patient over 60. And Margaret's story is the reason I believe that decision was the right one. Margaret was 74 years old when she came in for her annual physical. Her chief complaint was arthritis in her hands. That was what was on her mind. While she was there, I did her foot exam as part of my now standard protocol. When I tested sensation using the monofilament, Margaret could not feel two of the test points on the sole of her left foot, just two spots. It was subtle. In a rushed visit, I could easily have noted it as a minor variation and moved on. Instead, I ordered an HbA1c. Her result? 6.3%, pre-diabetic range. Her fasting glucose was 112 milligrams per deciliter, elevated, but not dramatically. In isolation, either of those numbers might have been watched and followed up loosely. Together, combined with early sensory loss in her foot, they told a clear story. Blood sugar had been creeping upward for at least 2 to 3 years, and the earliest neuropathic changes were already present in her peripheral nervous system. We caught it at the starting line. We had a detailed conversation about the glycemic impact of refined carbohydrates and made specific dietary modifications. We designed a structured walking program, 30 minutes, 5 days a week. We brought in a registered dietitian for 3 targeted sessions. 12 months later, Margaret's HbA1c was 5.7%, solidly in the normal range. Her monofilament test came back completely normal on both sides. The early neuropathy had reversed. She walks 3 miles a day now, tends her garden, and sends me a card every Christmas. The third patient I mentioned at the start of this video was Earl. Earl was 62, a long-haul truck driver, and he came in because he was having trouble feeling the gas pedal correctly. His right foot felt thick, almost wooden, and it was affecting his confidence behind the wheel. He was terrified because driving was his entire livelihood. When I examined him, he had lost protective sensation at 6 of the 10 monofilament test points. His HbA1c came back at 8.4%, full diabetic range, never previously diagnosed. The neuropathy in Earl's case was more advanced than Margaret's. We worked hard together, and we improved his numbers significantly, but he never fully recovered the sensation in that foot, and he had to step back from long-haul driving. He's managing well now, but the life he built around that career was forever changed. Different disease stage, different outcome. Same root cause that nobody had caught. The NIH research on neuropathy reversal is consistent and encouraging within its limits. Peripheral nerve fibers can regenerate. Unlike the central nervous system, the peripheral nervous system retains the biological machinery for fiber regrowth throughout life. Studies document regeneration rates of up to 10% per year when blood sugar is brought back into normal range within the first 2 years of neuropathy onset. The body is not finished. It wants to repair. The critical variable, the only critical variable, is catching the damage early enough that reversal is still biologically possible. Margaret's 2 spots came back. Earl's 6 points did not fully return. Harold never had that chance. Let me give you 3 things you can do starting today, not next week, today. The first is what I call the Sunday foot check, though honestly, pick whatever day works and make it sacred. Once a week, sit in good lighting, remove your socks, and give your feet 3 minutes of focused attention. Look at the skin. Is it dry, cracked, discolored, unusually pale, or red in patches? Look at your nails. Any thickening, yellowing, or crumbling? Scan the bottom of each foot for any wound, crack, or area of skin breakdown. Use your hands to compare the temperature of both feet side by side. If you have trouble seeing the soles clearly, use your phone camera or a small handheld mirror. There are inexpensive mirrors made specifically for this purpose. If you have a spouse or adult child nearby, recruit them. 4 eyes are better than 2, and someone who looks at your feet regularly will notice changes you might miss. This practice costs nothing and has the potential to catch a serious problem weeks or months before it would otherwise become visible. Second step, restructure just 1 meal a day around what I call a low spike plate. The most destructive dietary pattern for the peripheral nervous system and vascular tissue is the repeated glucose spike, the sharp rise and rapid fall that comes from meals built around refined carbohydrates. White bread, white rice, pasta, crackers, sugary drinks, ultra-processed cereals. These foods push blood glucose up steeply and repeatedly. And over years, that cumulative assault degrades both nerve function and vascular integrity. You do not need to overhaul your entire diet overnight. Replace one meal per day, ideally dinner, with a plate that centers on lean protein, healthy fat, and fiber-rich vegetables. A piece of salmon with roasted broccoli and olive oil. Chicken with a large salad and avocado. These meals slow glucose absorption, reduce the spike, and give your system a longer window of metabolic calm. Start with one, build from there. Third, and this is the habit I push hardest when I have a patient with any blood sugar concern, walk after you eat, specifically after your largest meal of the day. Aim for 10 to 15 minutes. Research supported by findings from George Washington University and several other institutions has demonstrated that brief post-meal walking can reduce the post-meal glucose spike by up to 30% compared to sitting. The mechanism is straightforward. When your skeletal muscles are active, they become highly efficient glucose consumers. They pull sugar out of the bloodstream and use it directly for energy, dramatically blunting the spike that would otherwise stress your vascular system. 15 minutes of walking after dinner, done consistently over 6 months, produces measurable changes in HbA1c. That is not a small thing. That is a free, accessible, zero side effect intervention that outperforms several supplements I've seen patients spend serious money on. And one last thing before I close, something I ask every patient to do at their very next appointment. Walk in and say these exact words. I'd like an HbA1c test and a foot exam. Not just a fasting glucose, an HbA1c. The distinction matters. Fasting glucose is a single data point, a snapshot of one morning. The HbA1c is a weighted average of your blood sugar across the previous 90 days. It reflects patterns that a single fasting measurement can easily miss. It is the difference between checking the weather on one afternoon and reviewing the last 3 months of climate data. You want the 3 months. And the foot exam. Ask for it specifically. It should be part of every primary care visit for adults over 50. And yet, it is still routinely skipped. You have every right to request it. I want to go back to Harold one final time. His blister became infected. The infection reached bone, osteomyelitis, which is one of the most difficult infections in medicine to eradicate. He was hospitalized for 11 days. He lost 2 toes on his right foot during that admission. He came home with a complex wound care regimen, a diabetes diagnosis that arrived nearly a decade too late, and a spirit that was, somehow, still intact. Harold was not a man who gave up easily. He came to every follow-up. He modified his diet. He walked with an offloading boot designed to redistribute pressure away from his compromised foot. He tried, but the vascular damage was too extensive, and his heart, which had been quietly burdened by years of uncontrolled glucose, elevated blood pressure, and the inflammation that accompanies both, could not sustain the fight. He died 22 months after his diagnosis. I carry Harold with me every time I put on my white coat. I carry him into every exam room, because what happened to him was not inevitable. It was preventable. It was preventable with a foot exam at a physical 6 years earlier. It was preventable with a follow-up HbA1c when that borderline glucose was first noted. It was preventable with a 5-minute conversation about what borderline actually means for a person's body and future. Somewhere in this audience, there is someone whose story is still in its early pages. There is a numb spot being blamed on the way they slept. There is a slow healing crack on a heel that's been there a month and hasn't worried anyone yet. There is a warning that hasn't been read as a warning. Your feet are talking. They have been talking. I am asking you, I am sincerely asking you to listen. If this video gave you something real, a sign to look for, a question to bring to your doctor, a story that made your own health feel worth fighting for, then please subscribe to this channel. Every week, I put out new content built around the health issues that matter most to people over 50, explained without jargon, without panic, and without an agenda beyond getting you better information.